It has been 5 years since publication of the final report and recommendations of the Global Review on Antimicrobial Resistance, and it's time for critical reflection on where we are today, where we need to be going, and how to get there. Antimicrobial resistance already poses enormous burdens on society, to healthcare systems and economies, and this burden will likely only increase. Indeed, the O'Neill Review estimated that inaction could cause 10 million deaths by 2050 and cost the global economy $100 trillion, a particularly harrowing prediction for the low and middle income countries. Worldwide, low and middle income countries today appear to be relying heavily on antimicrobials, especially antibiotics, to ensure medical, nutritional, and economic security. For example, imprudent and large-scale use of antibiotics is being substituted and compensating for the lack of universal access to clean water and sanitation, which cause the bulk of diarrheal diseases. Similarly, the misuse or overuse of antibiotics in animals as a prophylactic measure and growth promoter is driving a Faustian bargain, improving meat production in the short term, but undermining the usefulness of our current antibiotics and accelerating the time to judgment, the dire consequences predicted in the O'Neill Review.
Some people around the world often thought that when we talked about up to 10 million people dying every year by 2050 and the loss of an accumulated $100 trillion if we don't deal with AMR, many people thought we were exaggerating and it was crazy to talk in such terms. But in a peculiar way, this COVID pandemic has shed light on how those kind of devastating consequences actually are a reality. Crucial to the AMR one and future pandemics is there should be a lot more attention on disease prevention than disease management. One has to distinguish between investment spending and what economists call consumption or maintenance spending. And as we show with the AMR review, if you put it all together, we had 29 recommendations that we estimated would require $42 billion, which is a lot of money. But if it's going to stop 100 trillion lost, that's a 20,000% return. And economists call these things multipliers. And so if we had a much more transparent way of dividing spending into investment spending from current spending, I think it would allow a much more rational approach to planning for spending for disease prevention.
So I think that the main challenge when trying to if you want to make it more global or more on the global agenda, is that it's still very much driven by the health community. Health experts are very good at framing or understanding an issue and understanding what are the problems with the issue and communicating that. But that's the first step. So the second step is to actually make it to the political agenda. And here I think we have a problem, and it shouldn't be the health experts or indeed social science expert that should push the agenda, but a much more broader coalition of actors.
We can see that antimicrobial resistance has successfully, I would say, become stabilized as a political object, which you can see in part because it was made into an economic issue, and also because it was made into a global security issue, in addition to the health issue that we knew it was before. By labelling it an economic and a security issue, it focuses our minds on particular things that will address the security angle, for example, of antimicrobial resistance, which may cause us to focus more on spread and may cause us more to do certain things like extract information from some places to put on a global platform so that we can check whether AMR is moving around the world.
Data and evidence generation is crucial to underpinning context-specific action, but it does require effective translation into intervention and policy to be of value, and collaboration can be a key role in that translation. We do need to focus on collaborating across sectors, both public and private, and thinking who's going to be using the outputs and involving them in the partnership. So whether that be Ministry of Health or patients, they have a very key voice and should be at the table from the beginning. We also need to share learnings of best practice on how to collaborate, focus on building trust and understanding contexts of where we're working and sharing that value of our work, and also relying on process and protocols to help smooth those collaborations.
As we've learned in many, many other public health and climate change and other threats to humanity, these movements that really get people to pay attention are created by massive networks, coalitions of influencers. And I think AMR needs to move into that space of mobilizing these kind of actors rather than just relying on, though it is important, the popularization of scientific knowledge.
Despite the several political declarations and commitments made at the highest levels, global inaction to address drug-resistant infections is a significant problem given the scale and urgency of AMR today. We know that vaccines can prevent AMR, can stop epidemics of AMR pathogens. With a mission to discover, develop, and deliver safe, effective, and affordable vaccines for global health, we here at IVI focus primarily on vaccines that protect against infectious diseases that disproportionately affect low and middle-income countries. IVI's work on vaccines for AMR priority pathogens includes Group A strep, typhoid, non-typhoidal salmonella, Shigella, tuberculosis, and Staphylococcus aureus.